Welcome to the Silicon Fox podcast, where we explore the habits and stories of high performers. Join us as we dive into their journeys, analyze live blood tests, and break down the science behind key biomarkers to help you optimize your health. I'm your host, Mitchell Eschner, an ex-pro soccer player, a current sponsored hybrid athlete, a health tech founder, and a longevity enthusiast. Amy, thank you so much for hopping on the Silicon Fox podcast.
Thank you for having me on. This is great.
You've got quite the fascinating story, and I think it's always really useful for our listeners just to give you the chance to intro yourself a little bit at what you've been up to, what you've done. I think for this episode, I've actually just got like a subset of topics I want to talk to you about because a lot of them can be either controversial, but even just like hot topics where you have interesting takes. And so we'll honestly just go line item by line item. But first, I just want to
Cool.
give you the chance to introduce yourself. Who are you?
So I'm Amy Alkon, and I write, basically I call it applied behavioral science. I've written that for many years, and now I write applied medical science. And what applied means is that you can apply my critical evaluations and explanations and synthesizing of research, which I do in everyday language, sometimes with vulgarity and humor, to your life to, live more productively, less counterproductively, and to your medical care, because most of our medical care is not based in adequate evidence or supported by adequate evidence. And that is my experience, not just in my own care across different domains of medicine, but in I become this medical detective where I look at my friends, their clinical evaluations from their doctors, the diagnosis, the tests, and I'm able to help them and get the science-based care that they're not getting from their doctor and get the right tests or interpret them correctly, and that's something that's really important that we are not getting from medical care.
Absolutely. I love it. Well, I'm sure then we're going to have a lot of fun things to talk about. And I'd love to get like kind of detail oriented into any of these, but just some of the myths in medical care. So I think you argue that there was a few fantasies about our medical system,
Oh, it's
whether it's
terrible.
doctors
Yes.
relying on science, highly skilled like diagnostics, and all that kind of stuff. Would love to just like double click in those. What examples did you find that made this so prominent? And let's just go deep into some of them.
Sure. So there are three big myths about our medical care. And one is that doctors treat you according to scientific evidence. They understand that, read that, and then apply that to your care. And I can go into the details on these. The second one is that doctors are trained in diagnostic reasoning. That's a myth. And then the third myth is that doctors can correctly calculate your risk or benefit from a treatment or going without a treatment, and they put the number on that. Doctors can do none of these things. So medical research, medical schools, this is a moral deficiency of medical schools. They don't train doctors in how to read and critically evaluate research. When you go to the doctor, they don't read the scientific evidence because they don't know how. They're not reading it. They don't have time, but that's another story.
I have a small pushback for this, but
Oh,
I'm
good.
guessing, well, this is a hunch, and so I'd love to like dive deeper into this
You're a lonely
specific
cat
one.
lady?
Yeah, no, not at all. Is that like if doctors are being trained this way, there could be good reason for it, right? Unless we're going to take the stance that it's all a massive corrupt system where everyone's trying to make money and there's no incentive for doctors to do greater good, that then maybe my argument falls apart. But what I'm trying to make the stance is like there's times on the application layer of medicine to read research, and there's times to say, let's diagnose and give a pill, or let's do what's tried and true over the course of just my experience anecdotally, and we've seen that. And so I think because research often falters, you even made this point earlier when we were chatting, is that like a lot of these research papers, and I guess part of your point maybe is that you have to filter which ones are good or not, but a lot of them have lack of control groups, lack of edge cases. They don't have much application to them. And so there's a thesis and maybe the hypothesis is proven, but it's not really shown how to apply that to a patient segment. See, like I've spent some time reading research, not enough to really make it like a strong case, but of the research that I've read, none of it says, oh, based on this learning, this is what we should take away. This is how we should apply in the medical field. And so when you're teaching people, is like there's probably a lot more of an application layer to it. And so that's where I'd push back to say it's difficult to always look at things from a scientific perspective because often they're so not fully encapsulating that what hospitals and doctors are really good at is keeping you alive, not making you thrive, which is the point of research. My question more is not like yeah, okay, fine, they're not taught how to read research papers. That's incredibly problematic to be a doctor. But I could see the issue there. Where I don't see an issue is why do we need such when I give so much agency and ability for the doctor to act on their own behalf, not systematically that they're taught, we create a lot of positives with really capable people that say, "Oh, I read this new frontier research that proves that you can do X, and I'm going to do X on my patients." But see, when I do that, we also have a generation of doctors that aren't as capable that read these research papers, interpret them incorrectly, and do the negative thing. Thus, the most optimal kind of play here is to systematically train a generation of doctors that aren't reading research frontier and aren't doing new things, but are just again keeping people alive. Which on the margin, statistically, like hospitals are very good at
Okay.
keeping people
So
alive.
the practice standards of medicine are very often not evidence-based. Doctors don't know. They don't know physiology on the level they need to treat their patients. It's really, really terrible. I'll give you an example outside of menopause. I had 2 corneal endothelium transplants. But the thing is, okay, so I have an elite surgeon. I can tell because I assess medical care now for a living from her thinking and the way her colleagues talk about her, and I ask about her, that she's really medically prudent. She's probably very good. But what she doesn't know a thing about are the steroids she prescribes to patients. So she says, "Oh, I'll give you steroids for afterward." And I said, "Steroids? Oh, those can cause a lot of harm to your bones, and they can promote insulin resistance and other issues." And she said, "Oh no, they don't have these steroids. They're just in your eye. They don't have systemic effects." But I think, well, okay, this can't be because you have a punctal gland in your eye that, goes into your sinuses, and any kind of watery thing you put in your eye is going to have systemic effects. And prednisolone acetate, the steroid they give, it has a lot of systemic effects. And you can plug your little punctal gland with your finger, but you're not going to stop all of it. So if you just know one little area, like she does, and this is how medicine is, it's not her fault. The field standard is giving 4 drops of prednisolone acetate to prevent you from rejecting your transplant. 4 drops. Now, do they give that because they tested it against 3? No. Clinical habit, not based on evidence. Terrible. So she
Interesting.
figures this doctor, she went to Yale. She cares. She's really good. You can tell from her thinking. And she did studies while she was at Yale. So she can read a paper, but she's spending her time. You hope she's sticking an X-Acto in your eye. You want her to really be practicing that all day. So she thinks if 4 drops is good, 8 drops is better. And so I hadn't read the research. I just got out of my surgery, and you have to lay flat on your back. You're exhausted. And so I dutifully take these 8 drops, knowing that there might be systemic effects trying to do this. I was sick for months, and I had her stop this and put me on Lotamax ointment. So the clinical, all this stuff, there's so much lack of knowledge overall. Medicine's complex. They don't know this stuff. And I see this in every single area. Head of endocrinology says to me, "Oh, you don't want to take estrogen because that's going to raise your sex hormone binding globulin, which elevates when you eat a carnivore diet. You have low insulin. Mine's quite high." And I said, "Well, yes, that would be the case if I were taking oral estrogen, but I'm using transdermal sticker estrogen, and that raises it negligible amounts because one oral goes right to your liver, big blast of it, and transdermal negligible amounts get to your liver, trace amounts, and so it doesn't have the same action because physiologically it's metabolized differently."
But one of the things you covered that was the most shocking to me when looking up into some of your background was this calcium myth. Because in calcium, the reason I could bring it up, I mean, one of the company I work on is like we track a lot of these metrics non-invasively. We'll track calcium and potassium, magnesium, sodium, and so a big part of that is like a recommendation component, and we've been told for so long that like loading up on calcium is super important, avoids brittle bones, but there's science showing this is not completely necessary.
Yeah.
And actually, in a lot of these episodes recently, we've revealed so much that so many of these studies are so faulty and there's so many edge cases. So I'd love to hear about this
Yeah,
calcium myth
this
and
is
what's going
this
on
is
there.
so terrible. This is so horrible. They tell women to take these or men too, huge amounts of calcium, 1,500 milligrams, 1,200 milligrams. This is based on the notion that is not true to our physiology, that if you just down a bunch of calcium, it's like a fire hose into your bones. You have healthy bones. This is not how bones are formed. And taking this large blast, even if you take it in 3 doses, you can actually trigger a heart attack from this big bolus of calcium. And it seems like looking at ancestral research, so ancestral humans, modern hunter gatherers, looking at the calcium that they need, it looks like we need like 300 to maybe 700 milligrams of calcium. And you're going to get that through your diet. You
Is
know,
there like on the specifications of this though, like
Mhm.
this is specific to postmenopausal women, this is
Oh,
specific
no,
to the
to
masses,
everybody. Oh, no, to
to
everybody.
everybody?
It's
Okay.
so terrible. So the thing is, if you have excess calcium supplementation, this suppresses the secretion of parathyroid hormone, which is very vital for bone health. And that, the elevated calcium level in the blood from the, as I was saying, 500 milligram dose, this can provoke a heart attack.
Are you a health coach or running a health course and looking to level up your client's experience? With Cyphox Health at-home blood test, you can deliver lab-quality blood work right to your client's door. Seamlessly ship samples back for fast and actionable results. Personalize every consult with the data that matters. Clients who complete a Cyphox test are 60% more likely to enroll in a paid program after their consult compared to those who only join a sales call. If you're ready to give your clients the edge, go to cyphoxhealth.com/partner. And as a Silicon Fox podcast listener, enjoy 10% off your first bulk order. So what happened? Like, I'm just trying to understand the root cause of this because this is probably one of so many instances, and if we can kind of dissect what happened here, we can start to move on as to, why this is a broader issue across healthcare, which we'll jump into. And I'm sure you've got some interesting stuff to say there. But on the calcium side of things, like, how did this get so blown out of proportion? If it really is scientifically driven, number one, and number two is like, I guess you can speculate as to some motivation with pharma and drug supplementation companies, but like, how did recommendations get so inflated?
Okay, now big pharma. Guess what? Big pharma has a friend, out in the hippie table outside the health food store, and that's big vitamin. And the idea, this is the thing I see people say, oh, I'm not going to take a pharmaceutical, and then they're taking all these supplements, and they have no idea what's in them. This is the wild, wild west. And I belong to a site
Yeah.
called Consumer Lab, and I look at all the supplements and I use this because they send them out for independent testing. And so they see, does this have what it's supposed to have on the label? Is it adulterated? How much arsenic might there be in it? And then
Yeah.
I'm able to use it. The great thing is that, so the membership's maybe $50, but I'm able to get the cheapest vitamins. I found out that GNC and Swanson, they were like mall brands when I was growing up in Michigan. So you think like, they can't be very good. Oh my God, they're like pretty high quality and they're often quite cheap. And so you're able to save money, get the best, most effective vitamins, and they'll tell you which kinds are more effective than others. So that's very great
Yeah.
if you're a layperson who's not, knowing the difference between this kind of citicoline and that kind. They'll tell you it's all clear. So
But on the, like, the inflation portion, like, what along the stack did you find anything interesting in research is like to say, hey, there's a mass generation of researchers and studies saying that this is the recommended amount of calcium on a daily basis, but now it's so but now it's so that's an inflated quantity. Like, what happened? Was there a motivation to fudge this number? Was there faulty studies?
So what usually happens, I didn't look specifically in a lot of the cases in my book. I looked, I usually read the history on, how did it get this way? And so, with a lot of these, somebody makes an error or there's testing that is not up to modern standards. But this gets ingrained as here is what is in medical history and it gets passed on. This is what we do because we do it, and people don't check. And so, well, I can't tell you the history of this one. I'm sure it's very interesting. In other areas, that's really, I do that. I look back in the history because you want to see, for example, if there's research that somebody did with a method that wasn't modern, that needed retesting but was lost to history. And if you're a doctor and you went to med school, you're not trying to rethink everything like this, or like relook at things, investigate, well, is that right? You sort of accept things and move on. And when you don't have the orthodoxy, the medical orthodoxy, and you're not taught that everything's, here it is from my famous professor, then you look at things in a different way. And that's what I've done throughout the book.
You mentioned this a little bit, and I'm curious to dive deeper. And this is also one of the myths you talk about is diagnostic errors,
Mhm.
and just that whole realm. And you mentioned your friend's story. In America, there's almost 80,000 people a year that die from diagnostic errors. Like, what was the most interesting thing you found in that in terms of how that's, like, cultivated in this country? And, like,
What do you mean cultivated?
well, you kinda talk about it with the way that people get their degrees, and so, like, when you get an MD, you have a subset of maybe you call it like a grid of, if this then that's in terms of pills and whatever else, and there's kind of issues where if you misdiagnose, it causes problems. But how as a generation we do such a bad job diagnosing, or maybe you've read research enough to say, because I haven't, where actually over the course of time we've improved, in the past 10, 15 years. Because of
Well,
course 50 years ago we were much worse. So like what is this kind of diagnostic area you talk about in your book?
yeah, and this is my book, Going Menopausal, what you and your doctor need to know about the real science of menopause and perimenopause, because the big scandal of gynecology departments is that almost none of the doctors have any training or expertise or education in menopause and perimenopause. So doctors are not trained in diagnostic reasoning, and what that is to look for the nature of what's going on with you, what's going wrong, and the nature of it and the underlying cause. This is very important. So, an example is that you come into the emergency room with terrible headaches. Now, maybe you just have a terribly stressful job. You don't manage it well. These are stress headaches. You need to breathe or something like that. And so doctors it's called the viewing symptoms as disorders error. This is from Randy Nesse, who's the co-founder of evolutionary medicine. I respect him a great deal. And what this means is that doctors see the symptom and they treat that. They want to make that go away. No, we're human, so we have empathy for other people. Someone's suffering, you want your patient to stop suffering. And so there's a temptation to do that. But when doctors are not trained to look beyond that, they're more prone to do that. And so if that headache is just stress, great. But if they treat that and it's a brain tumor, they're masking the signs that you need to possibly save your life. And by the time you drop on the floor because it's so bad, you don't have the pain signal, maybe it's too late. And this happens over and over. And part of it too is also not knowing the correct physiology and the hormonal makeup of perimenopause, for example. So what doctors don't know about perimenopause, which is the transition years to menopause, 3 to 10 years before menopause. Menopause is 12 months without a period. And then in the time before, women are very symptomatic, and doctors think that estrogen is just, sort of running out like sand in an hourglass. And so they're missing, how to stop the suffering many women have, especially I was like this. Estrogen actually spikes and dives. And so it is not estrogen that causes hot flashes, but when there's a spike and dive, you have a freak out in your system, you have stress hormones that rise. And so a hot flash is not just uncomfortable, it's unhealthy, because you're having this, for women who are what? You're having basically chronic stress hormones jumping up. You're having this constant sort of like, immune system tax basically. And so, and then doctors also, they will prescribe women estrogen for the problems in perimenopause when you're having that spiking estrogen, sometimes 3 times the level, the normal in a normal menstrual cycle, because it's a menstrual cycle hormone. And so you're overdosing women on what's making them sick. And what doctors don't know is that the problem in perimenopause is that some women, and women, as they go through it, don't ovulate. And so what happens is estrogen, first part of the menstrual cycle, estrogen rises, a follicle comes up, a little sac with an egg in it, and that is supposed to rupture. And then the litter left over from the sac is called the corpus luteum. It's this yellow waxy stuff, and progesterone is made out of that. So in the latter stages, especially of perimenopause, but actually women go through this, and they're called anovulatory cycles, no ovulation cycles. If the sac doesn't rupture, you don't have progesterone made. Or if it's one of these rotten follicles, like later in perimenopause, you don't have a sufficient number of days. Now, progesterone helps you sleep. It potentiates GABA. You guys have probably heard of that. So this is like, progesterone is basically like the Valium of the human body. And it helps your mental health, sleep. It's helpful, as is estrogen, for cardiovascular health. Both help open your blood vessels with nitric oxide. Very, very important. And so, when you don't have progesterone, one of the things that happens to a lot of women is they get these inexplicable rages and you feel ashamed. It's horrible. Plus, the vital thing is if you don't have progesterone, you need this to protect your breasts and your endometrium, the uterine lining, from cancer. Estrogen is proliferative, and what progesterone does that's vitally important is it causes breast cells, not breast cells, generic cells in the breast. They're just like anything cells to specialize, to differentiate into breast cells. It gives them a job to do, so they're not delinquents. And what this means is they can't, like generic cells, double and redouble, and they can become cancer. So you're basically without this extremely important preventive, you're having the estrogen rise and then the progesterone cupboard is bare, you're at risk. And because doctors don't know the simple physiology of you need to have an ovulatory period to make progesterone, they're not filling in for the missing progesterone. Or they give, this is how my writing this book started. They gave on Kaiser's formulary for a long time, Kaiser, my provider, HMO, they had only medroxyprogesterone acetate. Now, this is a synthetic drug, knockoff of progesterone, and they had to make this because they couldn't get progesterone into your cells. It wasn't small enough, so they micronized it. 1980, they did this in France. Women in France have been taking this since 1980. And so medroxyprogesterone acetate, it was, one of the drugs it's Depo-Provera, birth control. So there are other hormone knockoffs too. But medroxyprogesterone acetate binds with the wrong receptor in the breast, increases breast cancer risk. It's harmful to the brain and harmful to the cardiovascular system, does not help you sleep. So they're giving this drug that's ineffective for your symptoms and that basically causes harm.
Yeah, crazy, crazy stuff.
Yeah.
Well, Amy, I'd love to jump into a quick rapid fire with you. I'm just gonna ask you a question. Just give me kind of the first thing that comes to
Okay.
mind. What's the most shocking thing you've learned while writing Going Menopostal?
Oh, I know. In research, oh my God, this has happened for decades. Big, famous researchers confuse medroxyprogesterone acetate with progesterone. And they will say, this woman, she has this paper where she says progesterone causes cancer. So being me, I'm this, crazy nerd. I go back and see all the citations to that, to support they're saying, making this claim. Who said this? What's the research? Oh my God, they're all medroxyprogesterone acetate. That they're two different things. Progesterone is a hormone in the female body. It's like saying NyQuil causes something. Like this is medroxyprogesterone acetate is a drug. One's a hormone, one's a drug. It's horrible, and this persists. And this is
You would
why.
think you would think that someone who's got who's got an audience would actually not too big to check, but do the vice versa. What's a study that everyone should read that wasn't part of Going Menopostal?
Oh, this is David Diamond, the LDL, LDL in a low carb diet. Do you have to worry about high LDL and a low carb diet? And isn't a study; it's a YouTube video because what I care about is that people have information presented in a way they can understand. And he presents the research. You can look it up. He gives you all of that, but it's explained so well that you can really understand this. And then also, so if you're a super nerd, the other one is Michael Eads on oh God, I'm not going to remember this now. It's on oh God, it's a new hypothesis on obesity, and it's a little
Okay,
complex. You
amazing.
might have to look up his
Well,
writing on it.
we'll read it. Great, Amy. Thank you so much for hopping on the Silken Fox podcast.
Thank you. Can I show my book again? I want to just see
Sure.
people. So it's called Going Menopostal, What You and Your Doctor Need to Know About the Real Science of Menopause and Perimenopause. You can get it at Amazon, Barnes& and Noble, indie booksellers. There's an audiobook. And there's also, it's affordable. And then if you want to subscribe to my free Substack, which is coming up twice monthly, subscribers at amyalkon.net. And please review my book because I need reviews. So thank you.
Amazing. We'll do it.